Let's see. Um, okay, so I just wanted to introduce myself, Peter Schneider, and I'm very fortunate to be joined this evening by Mike Watts and Ted Gifford. Mike and Ted, I'm going to have you go, I'll do something a little bit different, slightly different, have you introduce yourselves. But I'll just say both of these guys are real stars. But because they're working guys, they're not out every day goofing around very often like I am. So um, Mike is IR, was in academics, now mainly private, I think. Mike, why don't you tell us a little bit about yourself and what you're working on and what gets you excited? I know you do a lot of lower extremity stuff.
Yeah, so Mike Watts, I'm an interventional radiologist. So like Peter said, I was the fellowship director for IR at Penn until 2016. I was doing a lot of peripheral arterial disease, critical limb ischemia at that point at the Philadelphia VA. And a number of things changed about that time, and I kind of took the opportunity to leave the academic setting at that point, and I've been doing almost fully outpatient critical limb ischemia ever since. So the current iteration of my practice, I'm a partner in a large private radiology group, but we have a vascular institute which has 10 IRs, six vascular surgeons. We cover now five outpatient based labs that we own, three hospital systems as far as the IRs go. Our private group is actually joint ventures with those three hospital systems financially, so it works out well. And the vascular surgeons cover another half dozen or so hospitals. So my practice is all critical limb ischemia. When I'm in my outpatient lab, all morning I'm doing cases, all afternoon I'm seeing new patients, seeing some follow-ups, and I have full clinic days kind of geographically dispersed to help reach out to those patients and get different referrers from different wound care centers. I do wound care on my own, half day a week, or actually it's getting to be a half day every week. Again, to reach out to new referrers to actually get the patients with more longitudinal care. So it's high level, critical limb ischemia, a lot of inframalleolar reconstructions, really high end stuff from all over the southern half of New Jersey. And practice has been great. Like I said, vascular surgeons on board. So, if they see a patient who needs a pedal loop reconstruction and I see a patient who needs a common femoral end art, we'll just kind of trade them. So
Right.
it's really been a great practice for me.
Sounds really good. And I know you do a lot of inframalleolar, and that's of course, what we wanted to talk about today, which is I think a real growing area. It's always kind of been a little bit on the frontier of what we could do. So we have some tools now to kind of manage that, although we're still learning. Anyway, so Ted, let me just have you say a quick word. I'll just say Ted's a rising star. I've worked with Ted on a number of projects. He's in the academic world up at Connecticut, and but also in a big hospital with lots of trainees, et cetera. So slightly different practice venue, but same high level of enthusiasm. Yeah, please go ahead, Ted.
Yeah, thanks so much, Peter. I mean, thank you, Mike, for that wonderful, it's a tough act to follow. I feel like you really built a beautiful practice around taking care of these difficult to care for patients. So yeah, Ted Gifford, I'm up in Hartford, Connecticut. I'm a vascular surgeon. I've been about 7 years out of training now, and this is my first job out of training at Hartford Healthcare. So this is kind of a multi-institutional specialty system throughout Connecticut. We have both our main tertiary center in Hartford, but then we have a bunch of satellite hospitals as well. And getting started out at one of those satellite hospitals, I spent about half my time. We recognize there's a big unmet need for patients with CLTI. In particular, as you get out into rural areas, I'm sure, Mike, you see this out in some of the more rural parts of New Jersey, patients really have limited access to care. So as a result, myself, as well as some of our podiatry and wound care partners, kind of started a multidisciplinary limb preservation program. We've utilized nurse navigators to try to kind of bridge some of that gap and get patients timely care to, specialty referrals and also to get them, the procedures they need for revascularization. I've known Peter since I think, gosh, my first year in practice or something. We connected, and he's been a great mentor. I kind of was exposed to the Serenator early on, and in taking care of some of these patients, when I started, at least, a lot of my partners were wary. As you alluded to, treating below the ankle, there's kind of been mixed results. And although it's not necessarily a new therapy, I think people haven't really been sure what to do with it, how to achieve kind of a durable and successful result. I think nowadays we have more tools than ever before. But we noticed that we were able to start doing serrated angioplasty below the ankle and got fairly reasonable results, both good on-table angiographic results, but also good clinical results. And so that kind of led us to partner. We got a network of interested interventionalists, vascular surgeons around the country, and even some in Europe to kind of participate and submit their cases. And so we'll get a chance to talk about that today. So thanks to everybody for attending. Really look forward to a lively discussion and some great cases. Mike, I look forward to seeing what you've brought to the table because I know you guys do a lot of work down there in New Jersey.
Yeah, super. Well, so what I'll do is I'm just going to show a few brief slides to kind of frame a little bit what we're going to talk about and just a touch of the science behind it, and then I'm going to stop sharing my screen and have Mike and Ted each show some good clinical cases. So the whole concept of Serenator was born out of the fact that although we know and love balloon angioplasty and we've had it since day one, it might be the only technology I have in my life, plain balloon angioplasty, that existed for decades before I existed, and also has lasted throughout my practice career. So I don't want to diss or down talk plain balloon angioplasty, but the bottom line is we need better. We need a smooth surface with less dissection and better lumen gain. And that was where we were going with this idea of serration angioplasty. So in the same way that we want to really optimize and harness the balloon energy to give us a better result, we found that some uh, relatively, it's technically challenging to construct one of these, but the concept is beautifully simplistic. So, and let me just say we have balloon diameters from 2.5 to 6, 40s, 80s, 120s, et cetera. 014 for the BTK and 018 for the 4s, 5s, and 6s. And I think this is really helpful because this issue of creating a lumen is true wherever we go. Today, we're going to talk about the pedal arteries, where I would say, even more important that a lot of pedal angioplasty fails because the adequate lumen gain is never really there. It's not really ever adequate, and they very often go on to thrombose. So um, just proud to say that now we're going to have the SL Pro, which is a 2 millimeter diameter angioplasty balloon. This has two strips on it. This is 5 French compatible 014 guide wire compatibility. And this particular device, I think, will make this approach to the pedal arteries even more facilitated. The concept of serration. So, and I know, again, this sounds maybe too simple, but if someone steps on my foot wearing tennis shoes, it feels one way. The exact same person steps on my foot wearing stiletto heels, it feels completely differently. And that's really what's happening here. Rather than focal force, we're really talking about point force. And if you calculate, if you that you do the math to calculate how much force is exerted at the tip of each of these serrating elements, it's actually 1,000 times what you can get with plain balloon angioplasty. Whereas there are some other modified balloons out there, not really in the same zone as this, but the other modified balloons can create a somewhat of an increase in force up to 20 times what a plain balloon can do. But this is 1,000 times. And really it's intended to serrate, to actually create an opening in the artery wall so that once this series of openings is there, the artery, as the balloon energy takes over, the artery can literally start to unzip or to open along the dotted line. And this is, I think, why we get so much better lumen gain with serration angioplasty than with plain balloon or other types of tools. So this concept of low and slow inflation, so 4 atmospheres for 60 seconds, 6 atmospheres for 60 seconds, is actually not very common that you have to go above 6 atmospheres because the artery tends to open again. It's a combination of balloon energy and mechanical energy due to the point force. So, and you can see what these serrating elements do. They actually cause a divot or an opening in the artery wall. This is something we've seen with IVUS and OCT, and this ability for the artery to sort of open, like I said, along the dotted line is definitely there. So you just move forward. So, and this is, I think, what allows us to get a very low rate of CDTLR and also to mitigate recoil. And I'm going to come to the recoil in a second, and then to minimize the risk of dissection. So we did do a recoil study, and to some extent, we mimicked what was done in the famous Baumann paper, that we all know and we've all each quoted multiple times from 2014 in JEVT, where they looked at the result of balloon angioplasty, and then they kept the patient on the table for 10 to 15 minutes, and then looked again and found that recoil was present in most of the cases. Now, one thing we did in this recoil study that they didn't do in the Baumann experiment from 10 years previous is we actually used a very specific and very rigorous angioplasty protocol for the plain balloon angioplasty that was performed, a very slow and slow inflation to inflate the balloon and then keeping the balloon up quite a longer period of time. So we got less recoil than Baumann did. We got 55% of the lesions had a significant recoil, whereas Baumann had 97%. And I think this is because we used essentially a modern balloon angioplasty protocol for the tibials, whereas Serenator had 6% recoil at 15 minutes. So a dramatic improvement in recoil. And again, recoil is something that we talk about. We haven't really zeroed in on very well. But in this case, using a modern angioplasty protocol and a core lab adjudication, all in the tibial vessels, I think the tibials, maybe the pedals you could include, but the tibial vessels is where this probably matters most because we do get a lot of early failures after tibial angioplasty. And this, of course, are the ones that are typically being performed for limb salvage. And the patient's limb is at risk. So, and you can see we treated a number of different vessels in that study. So I'm gonna so that was really what I had to say. But before we move to the cases, maybe I could just hear, Mike, I know you've done a lot of training on this technology. Ted, I know you've used it a lot, and you also wrote the paper on. Actually, do I have a slide on the pedal angioplasty here? Let me see.
Yeah, I think we're
Ah,
going to go talk about some of the pedo results here from our paper that
yeah,
I alluded to earlier, which
yeah.
we
Why
can
don't you
definitely
jump
dive
in
right
here?
into. But I
Yeah,
think I'm going to set the stage a little bit about pedal artery intervention. And Mike, I mean, again, I think please feel free to chime in because the clinical expertise I think that you're offering here is really vital. But why do we care about this, right? Like, I think if we just kind of zoom out for a minute, Peter alluded to it when it comes to the fact that patients who need limb salvage, they tend to fail further down the leg. They fail in the tibials, they certainly fail in the foot because we really don't have any options to offer them. And is there data? Is there anything to support the idea that we should be trying to go after these things and open it up? There's a number of really good both registry data as well as single institution studies now that have looked at the impact of a patent pedal vessel and the ability to revascularize a occluded or diseased pedal vessel in terms of limb salvage. And in patients where you compare head to head, they have tibial disease and they have pedal disease and you're able to revascularize them, or pedal disease and you're not able to revascularize them, those that you're able to treat successfully have significant higher rates of limb salvage, overall freedom from major amputation. They heal their wounds shorter, faster. They require fewer reinterventions. So I think that really when we look at this group of patients, there's a reason why we want to try to help them. Obviously nowadays, I do think we have more than we've ever had in terms of being able to treat them. We've got some scaffolds kind of coming to the market. We've got limb flow for patients that truly have nothing you can revascularize. Although it's interesting, actually, we had a patient who failed limb flow the other day. They'd had a limb flow, it matured, they had a TMA, eventually the circuit went down and they were actually kind of rescued. Their foot wasn't really in super bad trouble. For those of you guys that are doing lymph flow, you kind of get a little bit of that neovascularization and stuff. But actually, what it was able to get them over to complete healing was then going in arterially and trying to get a little pedal work done. So again, I think having different devices and different tools in our armamentarium that we can use to treat these patients is really, really critical.
Yeah,
So
I'll jump in real
go
quick on
ahead.
that,
Yeah.
Ted. So, our practice has done a lot of DVAs. We started in 2018, and we were in Promise 3, and we're working with distal DVA now, and some devices with that. And what we're learning, you talked about some of this neovascularization. We're kind of talking about conversion of basically the circulation and all these things that we're trying to learn about DVA. But one of the things that we're learning is we want relatively high resistance, low flow through the DVA conduit. So we're not really getting that much steel. And we want a patent anterior tibial artery, if we're coming to the posterior, we want patent inframalleolar arteries that are still feeding the foot. So we're not getting ischemia during the time of this maturation and conversion. So if you can go down there and open up, the anterior tibial artery or whatever, and get a really good result, and they're always calcified, they're always terrible. That's why we're doing the DVA. And then we can make the conduit with the PT, allow that to kind of really fully mature and perfuse the foot while that single tibial runoff is maximized with the sterinator. We do that constantly. And it really helps the DVA storm. It really helps with ischemia, and I think it really helps with healing because you're not just giving up on the arteries. You need those arteries to actually still be effectively delivering oxygenated blood to the foot, while that DVA is working. So again, you're talking about things that you need to do to kind of salvage the foot of the DVA goes down, but we're using it to actually maximize the chance of the DVA working.
Yeah, I think that's an excellent point. I think that's a great point. And again, when we talk about all these things, there is a very clear anatomic transition point that we're going to talk about a little bit tonight between kind of the tibial vessels and the pedal vessels. But for all intents and purposes, what we're really trying to do is just how can we change the compliance of those really brittle vessels. So as we started treating some of these patients, we'll go back to that other slide for a second.
Okay.
Sorry, Peter. When we started treating those patients, I went to a local rep at the time, and they kind of went to the regional, and we found out that there were a number of centers, Mike being one of them, who was treating patients below the ankle with the serinator device and being able to successfully do it. And so we kind of got this whole group together and said, why don't we kind of report on our series? Very unstructured, right? All these are retrospective. We're not taking really close wound measurements, but let's just talk about kind of the feasibility of doing this. So we were able to get 45 patients in total. And as you can see, some of the patients had more than one treatment in a pedal vessel. But basically, we define the pedal anatomy as being anything below the talocrural joint. So anything below the level of the kind of medial lateral malleolus as it crosses into the ankle joint, predominantly being the DP, but then also the common plantar, the lateral plantar. There were a couple, one-offs of, we got one that was treated in kind of the pedal loop, the deep plantar. We got one in the medial plantar and one in the tarsal. As you can see, at this point in time, Cajun didn't have the 2.0, so we didn't have a balloon that was kind of purpose built to be able to get down there. We were doing this with a minimum size of 2.5 millimeters. A lot of previous plain balloon angioplasty studies are looking at treating the pedal vessels with a 1.5 or a 2. And I think the problem, as Peter alluded to with the recoil study, is that that's not going to do anything. It just doesn't stay open long enough. You have to treat it with something that is both big enough in diameter, but also somehow changes the compliance of the vessel. So in this case, we were treating with predominantly 2.5s, but you can see that even almost 10% of patients had a 3.5 millimeter balloon used below the ankle joints. Pretty impressive. So when we look, this is not a core lab study. This was all investigator reported. But when you look at kind of, how we define success, our main, endpoint of technical success was freedom from stenosis greater than 50% or immediate occlusion. And basically, we met that in all but 3 of our patients. We had one patient that had on-table occlusion. We had 2 patients that had a residual stenosis of greater than 50%. But overall, our median post-treatment stenosis was only 13%, pretty impressive. We had no episodes of perforation. When you think about using those little serrated point tips, you think, is that going to somehow injure these, especially these calcified vessels? There were no perforations, no embolizations. We did have one investigator that put some stents down below the ankle. When I was writing the manuscript, I actually found that that's been written up before. One can surmise the success of different types of stents below the ankle, but um, that is something that occasionally happens. One of the things that we found is really strongly associated with success was the better pedal runoff score that we could get for a patient after a procedure, the more likely they were to be able to heal their wound. Overall, you can see that, retreatment, again, this is kind of a brittle patient population, was in line with what we've seen in other tibial below the knee studies. But within the pedal vessels themselves, only about 15% required retreatment. And at 6 months, the freedom from reintervention of the pedal vessels was 93%. Again, overall in the cohort, only 3% or 3 patients in the cohorts required major amputation. And overall, at the 6 month kind of threshold where we have follow-up for patients, over or almost half of the patients had their wound healed, and almost 90% were on their way to complete wound healing. So, again, I think pretty promising results for this limited series and certainly difficult anatomy.
And then, just to summarize this work you did, or this work that sort of got together in this multi-center study for below the ankle. I mean, it seems like it's really quite common to have a really calcified segment either in the common plantar or the DP, even if the distal artery looks good, and having something that you can use to treat it that where the risk of a dissection or a sudden failure is so much less. In any event, so 93.3% freedom from CDTLR at 6 months, no perforation embolization, 4% bailout, 89% wound healing or improved at 5 months. So that's not bad. Now, let's see I'm going to stop sharing. And I don't know, Mike or Ted, maybe Mike, you want to jump in?
Yeah. So I got some cases, and we're talking pedal here. I think, I don't know the number that I submitted to that study, but it was a handful of cases, and there were pedal cases that I've shown before. So I was thinking, what have I done in the past, month or 6 weeks with Serenator that I kind of want to show off? So I have some pedal cases. Don't yell at me. I have some non-pedal cases too. But I think they really can show off some of the things that I'm really learning about. So if you let me run through a couple cases here, we can talk about them. We'll do some pedal and some non-pedal, but I think there's some interesting stuff here. So if you don't mind, I will share here. I'm going to start off with this non-pedal case. So I have practiced the vascular surgeons, IRs. Critical limb ischemia comes to me, critical limb ischemia comes to them. You don't always know what you're getting until you do some imaging. So I got this woman, she's 79. She's got all of the problems you could imagine. I mean, from her heart, from her lungs, from everything. And basically her problem here is this really nasty calcified common femoral. This has been a huge discovery for me over the past year or so. And she's got waxing away toe ulcerations, and she's got rest pain. So send her the surgeons. Surgeons talk to her. She's like, I don't want anybody cutting on me. I don't want this. I don't want that. So they asked me if there's anything I could do to at least temporize things. So this is what I've really been doing, and I have a number of cases of, I hate to say it, don't yell at me, common femoral disease. But you can see how bad this disease is, and what ends up happening is we just have super delayed flow down the SFA, down the profunda. And then when we actually kind of get through here, what I've been doing, I IVUS everything. I kind of get the best size I can. 6 was a little bit too big here, especially with how bad some of the really chunky calcification was. And this was just a low and slow 5mm Serenator. All it was, and then this is post. So this is immediate post. It looks great. The flow is so much better. And then I just lock this into the DCB. Do I have to? I don't know. Should I? I don't know, probably. But then we get this flow that comes through here, and we don't see the DCB doesn't add any extra lumen, right? The Serenator has done all the work. The low and slow Serenator, it's basically a 2-minute inflation, starting low and crank it up a little bit. And the results that we get are amazing. And this is the ultrasound, which you literally just got done. These, like I said, these are all in the past month or so. We have really great flow in the CFA. there's the calcium has basically been pushed aside, and a really good upstroke, multiphasic waveforms, and she does fantastic. I wanted to throw that in here because I was really excited about it as kind of a new case that I just did, but it just continues to prove a point. I have, a handful of these cases where there are things where you really don't have the option to do a lot of things. And these really badly calcified patients in these, no stent zones, there are people, the past 5, 6 years talking about putting Superas in the CFA and patients who are not or not surgery candidates. There are people who want to do all kinds of really aggressive atherectomy with filters and filters down the profunda and filters down the SFA. This has been a really simple, elegant, basically 20 or 30-minute solution that I've found for this problem. Not pedal.
Yeah.
I want to put it out there so you guys.
It's still a good case. And
It's a
one
great
nice
case.
thing about that case is even though the lesion was pretty complex, the bifurcation of the common femoral was intact.
Right.
So it's not like you're trying to do well, I think whenever you have disease that's right at the bifurcation, it's hard to treat that
Mhm.
without doing something like atherectomy or endarterectomy.
Sure.
But here, yeah, absolutely. And it's so interesting also because very often it's a little bit any port in a storm when you're dealing with CLTI or something like this. You have multi-level disease, you have maybe an elderly patient, not great for surgery. Having an extra tool in your armamentarium doesn't hurt.
Yeah,
Yeah,
and the
absolutely.
other thing you'll see through most of my images here, I think one of these is a hospital case, but for the most part, I'm outpatient based lab, right? So the marginal cost for a balloon, especially a balloon like this that does so much for the patient, gets such great results, is really inconsequential when it comes to the results and how we do it, and we've been doing that since the balloon came out. It's just become a real major part of what we do, and it's not even a second thought. And even to follow it up to DCB, right? It just the patients need what's done, to have what's done right and what's done based on the data. And I think the results really speak for themselves. So anyway, non-pedal case, we can get to a little bit more of a pedal case here. I don't know if Ted, you want to yell at me as a vascular surgeon for not, kind of pushing harder for an ENDART, but I think she'll be
Honestly,
um,
my philosophy towards this is that I chastise people who use the words never and always because I
mhm.
think that in our profession they don't exist. And as you point out, any port in a storm, you have to treat the patient safely. And I think that is definitely what you're doing there, what you showed there is a safe procedure. Your technical result at the end and follow up with the duplex all look good. You're not burning your bridges. You're not throwing a stent down your profunda or jailing your profunda with a stent down the SFA. You're not embolizing. You're not injuring the vessel. So again, and I'll tell you personally, I speak very honestly about the patients I've taken care of. You talked about atherectomy and stenting and all those things. All those things that I just rattled off, I've done. I've injured the
Sure.
vessel wall with
Same.
atherectomy. I've injured the common femoral and doing those things and had to cut down and convert to femoral endarterectomy. And, yeah, it's fine. I can do it myself, but it's still just as humbling, certainly humbling when I do it in front of the trainees. And I think, we got to be talking about all the different ways we treat patients.
Yeah, no, Ted, I've done bad things to vessels. I'm I'm the first to admit it. But you got to know, what you can do safely and kind of what your risks and benefits are.
Yeah.
Here's a guy, young guy, end-stage renal disease. The image on the left, I just stole from wound care, so I hadn't seen him at this point when he had a toe. So he had this necrotic toe, and they went and they removed this toe without really kind of evaluating effectively the pedal circulation. So what does that mean? When the hospital does an arterial duplex ultrasound, they look down to the ankle. They say, PT looks good at the ankle, DP looks okay. There's basically multiphasic waveforms, but you just know with these young type 1 diabetic end-stage renal disease, they can't really look too closely at the distal vasculature. They can get fooled a little bit. So when they take the toe off, we end up getting this image, down here on the right a couple weeks later. They've debrided it, it keeps getting this kind of, necrotic tissue back. There's a little bit of granulation down there, but it just, after a while, it's not healing. Unfortunately, a lot of times that's when they come to me. And this was a case I actually did at the hospital. And you can kind of see if you look at the runoff on the left, okay, well, there's a PT, there's a medial plantar, the lateral plantar kind of dies a little bit, but there's a DP. But any of us who kind of do these procedures a lot look at how that AT turns into a DP, and we know that there's a pretty significant occlusion there, and
Yeah.
those collaterals are taking a long time to fill that DP. That's not just kind of a direct flow. So when we get down to the distal AT and we inject, there's no real continuous path to this DP. And already with the lateral plantar as affected as it is, the medial plantar not making it past really the midfoot with some of those corkscrew collaterals, this guy's not getting any real good flow to his forefoot. So then we got to kind of make it work, and we got to do something that's going to last. So in this case, here we are on the left. We can't quite get down. You can see how calcified that is. Got to stick really, really distal, kind of out into some, kind of metatarsal artery down here. Work our way up, work our way down until we can get a wire across. And then when we can, this is a 2.5 120 balloon, serenator balloon, and this is what we get, right? So you can see, looking at that PT, still that lateral, even we get a little better view here. That PT is never going to feed that forefoot. We really need this continuous DP. As we get through that area of occlusion, you can still see where that calcification is. There's a little divot there, a little bump, but the density of that contrast, the rapidity of that contrast makes it to the forefoot. All of us who kind of evaluate when people show cases and say, someone says, hey, here's a great vessel, and you see it's super dark and then it turns light gray and it looks continuous. We know we haven't quite done the right thing. In this case, we definitely have, right? We see the DP come down and it actually dives down. We get our deep plantar, it makes a loop and it gives off our forefoot arteries. And then this guy heals up. So I think this case was in the past, it was past 2 months, and this was just last week. So I mean, this might be like a 6-week follow-up on that, 6 weeks, 8 weeks. To go
He
from
healed faster than I would have expected.
it healed very quickly. It
Yeah.
healed very, very quickly. But I think that the issue really is there's just such that there's a decent network of arteries going to that forefoot. There's just nothing feeding it, right? So everything's kind of hibernating. And when you can open it up and the recoil thing, it's so funny. I think about recoil and the study that was done, and it takes a lot of guts to look at a patient 15 minutes after you angioplasty him, because I think there are a lot of times where we get across a lesion and historically we balloon it and it looks good and everybody in the room is high-fiving and cheering, and somewhere in my head I'm like, I don't think this is gonna last, and I balloon it again for another 2 or 3 minutes and I take it out and I just have a sense that it's going to recoil, and apparently 55% of the time I'm right. But to know that we have 6 or 8 weeks and good wound care. So long story short, I do the wound care in this guy. It's actually turned out quite well, and the perfusion really is a huge part of this. But the thing about the pedal interventions that we do is, though these patients are really calcified through all of their arteries, most of them are pretty open kind of above the ankle, and getting the balloon down to the ankle and to the occlusion is really straightforward. And then these patients are all done antegrade, so you get a good leverage, get your sheath down. Most of these patients' fem-pop segments are completely clear. You get the sheath down to the trifurcation, and it's a good wire, and it's an easy maneuver, kind of through the occlusion. We open it up. In this case, was the 2.5 was the smallest that we had, but it seemed to fit just fine. We IVUS it and make sure that it's the right side. But this guy had a great result. So like I said,
So 2.5 by 40 for
that
that.
was the longer one.
120.
That was the 120.
Okay, so you used a long one. Wow.
Well, I used what the hospital had. Like I said, most of my cases are OBL. That was a hospital.
Right, right.
Similar story, right? So this is a guy right after an amputation. He's got the therapeutic cat hair going on there, and it's just a mess, right? It's just a necrotic mess. And the thing about some of these guys is it doesn't take much of a reduction of pressure head of the blood flow to get down there to have such a really kind of profound non-healing amputation site. So again, not quite pedal, but again, another great thing that I really like to take advantage for this device is AT was kind of decent to the ankle. It doesn't really give much of a DP. TP trunk is is basically there's a 99.99999% lesion there. So we cross that and we see that the PT feeds the entire foot. So we know that this is a major problem. This, sure, there are bioabsorbable stents now, the scaffold, not stents, but scaffolds, right? There are other coronary off-label stents. But if we really don't have to use those, as far as landing them and not jailing anything else, and we're going to do that every chance we get. And I'm a huge believer in IVUS, and everybody gets evaluated with IVUS. And when you get this really this kind of medium to lightish gray, really really chronic elastic plaque, you're in a real problem here, because there's some atherectomy that can help a little bit here. You start naming them, and I'll tell you why it doesn't work. And you really do need to make sure that you're doing something that affects this concentric plaque that's really elastic. You balloon it, it's going to come right back. Most of the things that we think about using tibial atherectomy, from CSI to laser, they're not removing any of this. It's not really doing the job. So I have found that these patients, do really, really, really well with serration angioplasty. And this is, you size it, you just do a nice slow prolonged inflation, you get these beautiful, beautiful results. I actually did go down and kind of play with his arch a little bit, and I'll show you that. But I came back, and this is a delayed image. So when I was saying you have to have guts to come back and look, I wanted to make sure that this looked, and 10 minutes, 15 minutes later, this still looked great. We end up with this posterior tibial feeding everything. It actually feeds the entire dorsalis pedis. The anterior tibial was kind of a fake out, right? Because it comes down and really kind of doesn't end at the dorsalis pedis. All of his dorsalis pedis flow and all of that forefoot flow is coming from that PT. So though this guy only had, basically in length, maybe 6 millimeters of a lesion in his entire vascular system, nothing was feeding his forefoot. And this was this week, I saw this guy. So he's definitely healing up. He's doing very, very well. The ultrasound looks fine. He's not quite there yet, but we're probably about 6 weeks out on this guy as well. All right.
Excellent.
Fun, right? These are just fun cases.
Good cases, yeah.
They're fun cases. So, and there's so many places where I think my techs who work with me all day start rolling my eyes, because it's if there's a place where you think angioplasty could work, there's a place where serration angioplasty works better. It's really what it comes down to. Last case, this guy just had these kind of ischemic looking toes, kind of cracked on the small toe, can't sleep at night. His small toe hurts so badly. He's got ischemic rest pain. He's getting up, he's walking around. This crack is starting to get necrotic. All the rest of his toes are no good. Runoff is really no good. So he's got a perineal that kind of feeds a little bit of the forefoot, which is kind of broken up. And he's got a PT, which is replaced just by these collaterals. There's no real legitimate PT here. As we get down the PT, we do see that we have a discontinuous posterior tibial. The common plantar is out, but we do have a lateral plantar that kind of feeds the forefoot. So we have some hope here, but we know this artery is in really bad trouble, and we know it's very small as well, which is kind of another concern. So we work our way down as far as we can with our sport catheter, inject. As you see, my injection basically fills veins rather than arteries. So we know we're really occlusive, but there is a lateral plantar that comes back down there. We can wire our way down through there with, just some patience and using some feel and some techniques that, we've all kind of mastered. And this was, I could not get my support catheter much beyond that. The wire was difficult to get down through. And this is the SL Pro, right? So this is the first chance that I got to play with the SL Pro. So if you remember, the common plantar was completely occluded. That whole posterior tibial everywhere in this whole image was just collaterals. And you can see the calcification down in the lateral plantar as we get a little bit further down there. So we're in the vessel. I ballooned it here to open up the common plantar, and then was able to slide it along right down into the rest of the lateral plantar. And we have a beautiful artery here. Like this is our 2 millimeter SL Pro. Was able to just work our way down through these long-term occlusions. I did some really good prolonged angioplasty. I started, kind of starting at the bottom of the calcaneus up, and then I was able to work it down through the rest of the lateral plantar. These occlusions are now gone. And then I did this case. So this was 4 weeks ago. So the first time I got my hand on it 3, 4 weeks ago. This was literally today. So brand new cases. That little crack is healing up. The toe is still a little bit red. The rest of them look relatively normal, and the man's sleeping at night. So,
That's a beautiful result.
it
And
was, isn't that
the
great?
only, I mean, I suppose you could do a bypass to the lateral plantar, but wow,
And
that's
here,
really
right?
out there.
Yeah.
And it's so interesting because now that we have Serenator, now that we have the ability to do a safer type of angioplasty, going past the ankle, we've always I think the normal way of approaching the foot has been to be a little bit like, hey, let's not do any harm.
Mhm.
And yet there are lesions there that, unless treated, the patient's just going to get worse, including this one. And this is a good example of that. And so having something a little safer, with less likely of an acute vessel shutdown or disruption, et cetera, and to be able to create inline flow like that to the foot, that's a really nice result for
Yeah,
this guy.
I was really excited to share this one. This was kind of high fives all over the place. And he's just got he's got such little flow elsewhere. As his perineal, his AT is basically gone. His perineal is somewhere in the 1 to 1 to 1 to a quarter millimeters in diameter. You can't do much with it. But he had his PT, is just asking for flow, and it's going to perfuse the foot, and you can just see immediately the pain's gone. That little crack heals up within the matter of a month or so, and he's gonna.
Yeah, nice.
That,
Yeah.
And
that,
there's plenty of data out there, like from the Rendezvous Registry and other series or trials that show faster wound healing, et cetera. But I think people are still a little bit reluctant because of that fear, like, what happens if kind of thing.
Mhm.
And this is, I think, where Serenator comes in. So, anyways, Ted,
Yeah, sure,
you want to
absolutely.
jump in?
Let me pull up my
Great cases. I see, Mike,
those
you
really
have
those are
is that a featured background, or is that really your wine cellar there behind you?
interactive
it's all real.
background.
There's a 1980s. There's a 1980s Chapelet there, Peter.
Oh my
That's
gosh.
There you
that's a
go.
good
Oh
one.
my.
Might want to hold on to that one.
Because
Wow.
Cajun doesn't supply the background, unfortunately. But
Yeah.
Grace Family. There's a good one too. I'm, I'm full of them. But yeah,
Excellent.
these are for real.
So Ted, what do you got?
so you guys see my screen okay?
We
Uh,
can.
those are great cases, Mike. I have to say. I mean, again, I think the other thing, this case, I think shows it very well. But I'm not knowledgeable enough to be able to recount the history of the idea behind angiosomal directed revascularization. But I think that historically, it was people when people said, "Oh, it doesn't really matter." It might have been because we didn't have the tools to get us there. I think now that we're looking at some of the pedal data, there's a very nice European study out of Italy that looked at, again, pedal revascularization versus non-pedal revascularization and showed that angiosomal directed pedal revascularization made a big difference in terms of freedom from major amputation and wound healing. So I really think that while before we were saying, hey, any flow to the foot, quote, inline flow to the foot, we'll look at those perineal collaterals and, maybe that's enough for us. I think now that we have some of these tools, we really want to dig a little deeper. So I'll go over a few cases really briefly. And, again, I think that last case, Mike, that you ended with was just such a great testament to the new SL Pro. I'll show you my SL Pro case. I don't know if I'm going to match that, but this was a guy I treated a while back. So it's an interesting case. He had this really small diabetic, dorsal foot ulcer. It kind of came out of nowhere. Wasn't even really a plantar diabetic ulcer. He was referred to one of my partners, and you can see on his non-invasive, non-compressible, had some kind of blunted metatarsal waveforms. So they took him for an angiogram, And you can see again, this is kind of what they saw. They saw perineal and not a lot else. I'll show you the kind of dynamic angiogram in a second, but at that point they said, well, he's got inline flow to the foot because he had no other lesion. But if you look at this, I think it's hard to argue this is inline flow to the foot. This is inline flow maybe to the ankle, and then
It's
that's about it,
horrible.
right?
Yeah, you're not going to heal anything with that.
And so he wasn't going to heal that wound, and sure enough, he didn't. In fact, he just progressed. So this was again about a month later. Now we have a very similar to your group, Mike. We have a very collaborative group, and we all kind of work in the same offices. We have our podiatrists immediately next door. So they came over and grabbed us, and they said, this guy's not healing. What else can you guys contemplate doing? So same thing I did, ipsilateral antegrade. I think that's a really important thing for a pedal revascularization. I think it makes it quick. Most of these patients don't have fempop disease, and you can park a sheet down in the distal pop and just go to work, like you say, it gives you so much more pushability. In this case, I also prepped the foot because when I looked at his initial angiogram, you can see here when you actually do the dynamic run that something comes back, right? In particular, that little DP comes back there in the foot. And so I felt like it was worthwhile. I wasn't sure if I was going to be able to cross that antegrade. It's worthwhile just to have the foot ready to go. And sure enough, I ended up, let's see, go to the next slide here. I ended up having to stick the foot, kind of go through and through, cannulate my catheter from below. And then I took, in this case, I ended up doing a 2.5 predil, but I sized that proximal AT at 3 millimeters. And I said, what the heck, let's just take it up to 3 and see how it goes. I think low and slow is the key, but you can see what a difference now. This is shot from up at his popliteal, and you can see you're barely seeing that perineal and the perineal branches fill. Really what you're seeing is not just the AT-DP, but you're seeing kind of the dorsal loop fill as well. And again, very safe, you don't see any dissection there. You see really just amazing restoration of a flow lumen, with essentially just a balloon angioplasty, but with a very specialized balloon angioplasty. Um, Again, this was a little bit ago, so he has not required anything. This was him back in the office, healing his intervention. You can see what a difference his digital waveforms made in between his first one and his follow-up. So, very nice guy. We continue to see him in the office and just monitor him and his other foot for any disease. But I think just again a testament to the fact that a lot of these patients, when we talk about why does this work for us, anecdotally, I say, well, I don't find myself going back and treating them again. And I think that is something we do in BTK disease, and we shouldn't feel bad about having to do it because we got to fight for every little yardage that we're going to get. But, again, I think I find that the lack of recoil and the safety in using this balloon is really effective.
That's a beautiful result, kind of similar to what Mike was showing. You look at the initial angiogram, you go like, oh my gosh, this guy's in real trouble. And without opening that ATDP, I don't know how this guy wouldn't just keep progressing until suddenly he's a BK. Yeah.
Yeah. One of
Yeah.
the things that I found really interesting, I think this one kind of shows that this is an older patient that saw me with kind of like that last case that you showed, Mike. She was, had that lateral kind of fifth toe ulceration. I unfortunately didn't have a before photo because I don't do my own wound care. I should do my own wound care. I think it's a really important part of the work that we're doing here. But she showed up kind of smoker. She'd had some prior tibial work done. And I think at first glance, if you look at her, right, again, you see this is her BK segment. You see the proximal tibials. AT looks like it's doing okay, but down at the foot doesn't actually seem to do much. Show that run. And then you can see the perineal and the PT just diffusely diseased, this little string. And on first look, when I'm looking at her foot, I'm not thinking a whole lot. I see the lateral plantar, but I wasn't like overly enamored by it. You see the AT doesn't really give rise to any DP down there in the foot. I think doing a more directed lateral shot's important. But the other thing that I thought was important, so when I actually got down there, kind of got down through that PT, nothing really wanted to go very far, and then took a shot, then you can really appreciate that lateral plantar being a much more robust target. And I think that's another important point of pedal intervention is that you really want to try to interrogate your outflow. We talk about hibernating vessels and all this stuff, and I think that sometimes when I started out as an early vascular surgeon or was as a trainee, I was like, oh, I don't know if I believe in all that stuff. But I don't think we're looking for it, you know. I think once you go down and you really start looking for it, you start to find that outflow.
So not to interrupt you, but
Yeah.
I showed you some case where I do the same thing. I get that catheter as far down as I can. And I've been in a situation before where I've injected contrast and not really liked what I've seen and not really see where something comes back. I've injected CO2, just in a blast of CO2, and the viscosity is so much less. It can travel through some of these little collaterals and find a hibernating vessel. Now, it's uncomfortable for the patient and it's hard to get a good image,
Yeah.
them staying still, but it really does help from time to time finding that lateral plantar or finding where kind of if that DP comes back from somewhere in the PT, from some collateral. I found it to be really helpful, and it's again, you get to, I've been doing this for long enough. You look for things that are fun. Finding ways to use the serinator is fun, and finding ways to use CO2 is fun, and you can do them together even better.
Great.
I have a hard time. I can't get them to not move their foot. You know, I find I'd be curious if somebody put CO2 down my leg, what it would feel like, because it always just looks so uncomfortable for the patients when they're kind
It's
of
a
jumping
direct
around.
acid, right? Proton donor or whatever. It hurts. I mean, it acidifies everything, and
Yeah, it's an
can't be good.
impressive recall. Yeah. Um, So, you know, this is an interesting thing where you say, well, should we stop? Should we keep doing more? So obviously, the first thing I wanted to do was to get her PT open. And I took a 2.5 serinator and just started kind of going down. And this was kind of a reverse case. Usually I like to go down, but sometimes the vessel's not compliant. It's not going to let the balloon go down there. So I will, when that happens, kind of inchworm my way down there. And I did. And I got, you can see the caliber change all the way down to the level of the ankle. But then you see the common plantar and the lateral plantar, and you think, okay, am I going to just stop with that and leave that as my outflow, or am I going to try to treat it? And I'll be honest, I think there are some people that would have said previously, I'm just going to leave that alone. I don't want to injure that vessel. When I think about the worst thing, I had a patient on the table the other day, and I was struggling with this because I couldn't get my wire into my pedal loop the way I wanted it to. It kept going into the like lateral tarsal and it wouldn't go into the dominant DP. And eventually I stopped. I said, I'm going to bring this guy back because I think the worst thing you can do to a patient is take their foot and make it, you know, acutely ischemic on the table, right? A wound, you can come back and try to treat it again. You can try to tackle another way. So I think we're always fearful that we're going to cause injury. But I have felt now using this balloon that if I can get a wire across where I want to go, I feel very safe in treating with it. And so I took the 2.5 down all the way around down to kind of the mid calcaneus there, and you can see again with this outflow kind of what a difference that makes in terms of the perfusion and the flow into the distal foot. And
Another fantastic result.
yeah,
That looks
yeah.
terrific.
Yeah, she's done very well. Oh yeah, I didn't have my follow picture, but she has not required reintervention either.
You'd never
Um,
expect to see a vessel like that from your initial runoff, ever.
yeah, exactly,
Yeah.
right. I think it's that you get down, you do find that hibernating vessel, and then you can change the compliance of the vessel, especially those proximal parts. You know, I think getting further out is always going to be tough, but we didn't have to in this case, right? We just took it down to the distal common plantar, right? The kind of bifurcation of the medial and lateral, and that was sufficient. Um, This is my last one here. This is interesting. So these are like the kind of inpatients we get. You know, this very, very nice guy, but showed up kind of out of nowhere, no prior interventions. And I was going to throw his CT on here, but just rest assured he had multi-level disease. And I did decide at that point that I was going to take him for a FEM-ENDART. So this was actually when I was thinking about, we had the SL Pro available, and I'd had two really tough cases earlier on where I wasn't able to get, a good wire access to be able to treat somebody. And I thought, well, maybe this guy will have something, although I got to do an inflow procedure on him. So I did this femoral reconstruction. His SFA is occluded. You can see his SFA pop after I did the inflow. And then you can see after I cross, his pop comes back and his AT looks like it's going to be great. And I thought, well, the PT and the perineal look like garbage, but the AT looks great, so sure, it's going to look fine on the foot. But actually, and I'll show the dynamic shot in a second, but down in the foot, his AT was gone. And I look at his PT again, and I kind of see these tandem areas, and I see this little tiny PT down at the ankle, tiny plantar down at the ankle, and this beautiful lateral plantar coming back. I mean, that is a target where I said, Gosh, and I
Yeah.
wanted to convert this guy to a bypass. That's a beautiful distal target there. But after we kind of got everything done, sure enough, we took the SL Pro and it just boom right down. And you can see tracks all the way down to the lateral plantar. And then at the end, again, this is kind of the completion shot. So you can see now like why the AT was not going to be the target for him, and actually probably why I think he had some of that initial disease. I suspect. Obviously, he didn't embolize because this was, I mean, if you looked at his common femoral, it was like just a giant wall of calcium. But I think he did maybe have some thrombosis of that DP there to cause some of that soft tissue ischemia. But again, you can see this was about 15 minutes after our balloon, no recoil, really nice angiographic result. We took it kind of on the way out. And this is him today, actually, in the office. So I'm back. This was about 4 or 5, 6 weeks ago that we treated him. And again, now you can see, just really holding up very nicely. He has a palpable PT on exam, maintained with an antiplatelet and an anticoagulant. So, I think these are all really nice examples of just how we can kind of treat stem to stern very safely, very effectively, and quickly too. Again, this doesn't require a lot of device setup or device prep. We just kind of put the balloon in and go.
Another great case, and another example of where if you weren't willing to go to where the disease extends to all the way down into the foot, and the patient's going to continue to worsen. So really nice. And we have just a couple minutes left, but I just wanted to get your guys' opinion. We had a question in the chat about choice of wires, and Mike answered it, but I wonder if we could just talk about it for just a moment, some of the technical aspects. And I see, Mike, you say you like the Glide Advantage 014. I agree with you, by the way. That's an awesome wire. And some of the Asahi. So maybe just tell, when do you pull out the Asahi wires, and then we'll go to Ted.
Yeah, so the Glide Advantage does a great job maintaining its tip, I think. So when you're trying to get around things, it's probably the best option we have. But the shaft isn't quite as firm as some of the Asahi wires or Regalia or something, kind of in that family. So I really like the Glide Advantage for the tip. It does have decent, kind of stability. But if it's just, if you're going to be pushing, a balloon through some bad calcified occlusions, I'm happy to switch out for something. And like I said, the Regalia has a good tip as well. It's a little bit stiffer. But I just find that it doesn't maintain its tip if you're trying like just so you're talking about, Ted, you're trying to get in the DP, you're going to the tarsal, you're going to the tarsal, you take that wire out and it's pigtailed and it's lost, right? So then you're opening another one and another one. The Advantage doesn't seem to do that quite as much. So that's kind of my go-tos down below the ankle.
Yeah,
And
I
what, do
think that's
you have a special wire for occlusions, Mike?
Yeah, so I will O&A command basically, anything down to the ankle, especially when you see that you can see the path and you kind of keep it straight. It does a great job, and it's become kind of an extension of my hand where I kind of know how it feels and what's going to happen. Once I get down to the ankle, I have used like an Asahi, like an 014 Mongo wire. Again, good kind of wire to go to. I don't do a lot of weighted tip wires. I have Victory 014s, but I find that we can work our way through rather than actually increasing the tip weight, especially when we're down below the ankle.
Yeah, sorry I interrupted you, Ted. What
No, no,
what,
no.
what do
I
you
was
think?
gonna, I was gonna pretty much agree with that whole statement. I don't use, if I really see a cap, I'll use a weighted tip wire and try to just puncture. But I think most of the time, my workhorse is a command, a 014 command like ES, and I usually use, especially to get down there, I'll use my catheter. So I almost always just park my catheter, a millimeter behind the tip of my wire and just try to just go, like you say, with feel. For some of those really curvy vessels. I love the idea of the 014 Glide Advantage. I do think that it almost kind of somersaults through some of those things. I'll use choice PTs and just see if I can get it to kind of, it's got that nice long hydrophilic floppy tip and try to get it to find that channel. But you can burn through it. It just,
I, I, I used to
it's a one and done. Either you got it or you don't got
I
it.
used to use
And
a run through for that.
yeah,
Get a
exactly.
30 centimeter 30 centimeter floppy tip. You're like, well, it's either going to go or it's not.
That was the run through.
And
That's funny. That's a big workhorse wire in our group, and It's been around for a long time. I always get nervous about. I've tied the run through in knots a couple times, and then you're like
Yeah.
trying to get it out, and
I've
it
tied
doesn't.
everything in a knot, so it's okay.
And put it through a
Um,
collateral bed that you didn't think would accept a wire,
That's
probably.
exactly right. Yeah.
yeah.
Tell me just briefly, we're over time, but I just want to get just for the audience, give us a quick one-liner on your favorite support catheters. Maybe each could, what do you support your 014 Glide Advantage with? What's your favorite? Maybe Mike, why don't you go first?
I start everything with a Rubicon, and then when I get down to the ankle, I'll usually switch out for an 014 CXI. I don't have access to a lot of the coronary kind of fun catheters, but those get me kind of usually where I'm going. The kind of extruded tube Rubicon gives me a good pushability, and then when I needed something a little bit more flexible, and I think the CXI has a 2 degree curve on it.
Right. There is a
Everyone's
little, yeah.
yeah,
that's a nice support catheter for.
yeah, it
And what do you
helps
say,
with
Ted?
flexibility.
I used to start all my cases with, I used to be just like quick cross exclusive. I love the visibility of it. It's so easy to see. And I found that I would never use the 014 because I didn't think it was very pushable. I would just try to do everything through an 018. And I've gone to the CXI more recently because I found that in areas where it's not like the quick cross is not very lubricious. And I think that the hydrophilic coating and the braided tip of the CXI is actually really really gotten me where I haven't been able to push across. I also like just the coaxial stuff. There was one of those cases, I think the second case I did, I actually went up and over, but the coaxial CXIs, if you're using like a 70 centimeter treatment sheath from the other side and you're parked in like the mid SFA, you put an 035 down, put an 035/90 down to the distal pop and then you can put the 135 or 150 CXI through that. And I think that's a nice system.
Well, and I think people can tell by hearing you both talk that there is an art to this, that there is a set of tools that are becoming more specific, or at least that each person has to decide specifically what works for them. But I think when you add Serenader to it, it becomes as close to a package of instruments that you need to get these things open as we have in other vascular beds. We obviously we want to avoid implants down here. So, and you both showed some great cases. Now, because it's after 9 p.m. on the East Coast, I strongly encourage both of you to take the rest of the day off. And really appreciate your coming on. I loved the cases; they were awesome, and hopefully everybody got a lot out of that. And really great to hear two experts talk about what they love to do. So thanks for that, guys.
Thank you, Peter. And
Yeah.
thank you to all the attendees. Really appreciate you guys turning in.
Absolutely. All right. Have a nice evening.